Welcome to AETCM, the emergency medicine channel. Today, let us discuss about diabetic ketoacidosis. Last time we have discussed about another emergency in diabetic patient, that is hyperosmolar coma. Here we are discussing about diabetic ketoacidosis. So the word itself tell you what it is. Diabetes is there, uncontrolled diabetes is there. Ketone bodies are formed here because of the insulin deficiency, then that leads to acidosis. So three important problems: diabetes, uncontrolled diabetes, insulin deficiency, ketone body formation. Because of that ketone bodies leads to acidosis. Now, it's one of the important emergency in diabetic patients, uncontrolled diabetic patients. The main problems are very high blood sugar, hyperglycemia, then dehydration. Because of high blood sugar, patient loses large amount of water from the body through kidneys. Then that produces ketone bodies in our blood that leads to acidosis. So acidosis can be various other reasons like sepsis, lactic acidosis, renal failure, liver failure, but here the acidosis is due to ketone body production. So these are the problems in metabolism due to insulin deficiency. There are some important reasons for DKA that is triggers. One of the most important reason is infection and sudden stoppage of insulin or missing the doses that also can produce DKA. Some patients, all of a sudden, they present to emergency room with DKA. That may be the first time they are coming to the hospital. So they might not be previously they never detected for diabetes and they are not on any treatment. Now coming with DKA suddenly to emergency room, that is also possible. So very high blood sugar, but some patients it may be even 250 or 300 milligrams. Some patients even euglycemic decay also can occur. The sugars may be even normal, but normally as a general principle, sugars are very high, more than 300. Bicarbonate is very low, that indicates acidosis, and pH is very low, less than 7.3. Patient can have serum ketone bodies positive and urine ketone bodies positive. This is more specific. Serum ketone bodies are more specific. So that will be positive. Ketone in the urines are also positive. And severe dehydration. Patient will have all signs of dehydration. Even in emergency room, we can do ultrasound and find out whether IVC is full or empty. Now, various reasons we have checked. In that, most important is infection like pneumonia, urinary tract infection, and sepsis. One of the most important reasons for DKA is urinary tract infection. Inadequate insulin treatment or missing or non-compliance to treatment, that is very, very important. Some patients, especially elderly individuals, they miss the doses and come back with the DKA. Now, stroke, myocardial infarction, they are also very important. Some patients can develop stroke or myocardial infarction during DKA because of the hyperviscosity produced by severe dehydration. Pregnancy, alcohol ingestion, these are the other two important reasons for DKA. Triad, we have already seen, very high blood sugar, more than 300. Severe dehydration, hyperketonemia, that means ketone bodies are positive in your blood, and patient develops metabolic acidosis because of the ketone bodies. Now, ketone bodies are produced because of insulin deficiency, activation of lipolysis, increased plasma free fatty acids that produces ketogenesis, gluconeogenesis, hyperglycemia, osmotic diuresis, volume depletion will produce dehydration. So dehydration is produced in this pathway. Ketone bodies are produced in this pathway. Both together will produce ketoacidosis with dehydration. Now, insulin deficiency is the major reason here, but comparing with HHS, the absolute insulin deficiency is seen in DKA, whereas there will be minimal insulin present in the HHS. That's why they don't go to acidosis or ketone body production. Here, ketone body production is absolute due to absolute deficiency of insulin. That is very important. Now symptoms: patient can have polyuria, increased thirst, weight loss, weakness, nausea, vomiting, leg cramps, blurred vision, abdominal pain. Patient can have dehydration, hypotension, cold extremities, peripheral cyanosis, tachycardia, air hunger, that is called as Kussmaul's breathing, that is there in all types of major acidosis including ketoacidosis, smell of acetone, hypothermia, confusion, drowsiness, coma. Whatever it is, a patient who is having high blood sugar, who is having rapid breathing in emergency medicine department means rapid breathing means mostly this can be DKA or some emergency like sepsis or myocardial infarction. All these things also can mimic. But somebody is having very high blood sugar, altered behavior, increased breathing tendency because of the acidosis, then mostly it is DKA. Non-ketotic hyperosmolar coma, we have discussed last time. The major difference between DK and HHS is here water loss is very high. Water loss is around 10 liters in this one, whereas DK it is 6 to 8 liters, and there is no ketone production, ketone body production here. That's why patient will not go to acidosis. But remember, some HHS patients can have some amount of decay. So some same patient, both the condition can coexist, and HHS patient can have acidosis because of other reasons also, like lactic acidosis, renal failure, all these things produces acidosis in HHS. So we are not going to treat these conditions in isolation. We are going to treat the patient as a whole. Whether the patient is having HHS or DK, the basic problem is same. Patient is having dehydration, patient is having insulinopenia. These are the main two things, and some patients can have infection, myocardial infarction, or a predisposing condition for this. So the major differences between HHS and DK. So you have already seen that the blood sugars in DK are high, and it is higher than that. And serum sodium, normally when the sugars are very high, sodium is low in DK. It is slightly normal or higher in HHS. Urea creatinine is mildly elevated in DKA, and it is grossly elevated because of severe dehydration. Serum osmolality is very high or increased in HHS, that is very important. Ketone bodies are present in DKA and they are not routinely present, and very rarely some patients can have ketone bodies positive because of other reasons. Bicarbonate is low because of acidosis here, it is low here. Blood pH is low because of acidosis. Here it is normally pH is normal, but patient who is having lactic acidosis and all, it can even low. DK is a high anion gap metabolic acidosis, whereas there is no acidosis here. Insulin requirement is very high because it's insulinopenia and it is a relative deficiency of insulin. So that is a difference. Now fluid deficit in DK is around 6 to 8 liters, whereas HHS is very high. It is 10 liters, 3 liters intravascular, extravascular, 3 liters intravascular. 3 liters extravascular can be corrected with normal saline. Intravascular should be corrected with dextrose. So that is very important. Sodium deficiency is around 7 to 10 milliequivalents per kg per body. Potassium deficit is very, very important because when you are giving insulin, you have to always check the potassium. There will be a deficiency in potassium, and if the potassium is already deficient, then when you are giving insulin, again shift can occur. Patient can have shift hypokalemia, that may be dangerous on that time. So we have to be very careful. Phosphate deficiency can be there in many patients. Magnesium deficiency is actually seen in many patients, and it is very, very important because the action of insulin, the intake of insulin to the cell is facilitated or mediated through magnesium or by magnesium. So the level of magnesium is very, very important. Calcium deficit is also seen in many patients. So all these electrolytes we have to check in patients who is having DKA. Now ketone bodies are present in blood or urine. Serum ketone should be checked during the initial phase, and once the patient is having recovery, you can check it. And daily checking may not be very useful. Once the anion gap is closed, then you can check the ketone bodies and make sure that it is completely absent. ABG is very important in acute phase of DKA, but for follow-up, ABG as such is not required. You can go even for VBG. ABGs is actually we are taking blood from the artery. They are painful. They are very costly investigation. So to know the pH value, you can actually take the venous sample and send it to lab. That is also enough. So that is very important. Then you know that it's a high anion gap metabolic acidosis. So anion gap can be calculated by serum sodium minus serum chloride plus bicarbonate. Normal anion gap is 12 plus or minus 2. So high anion gap means it is more than 14. So in many patients with DKA, you can see this anion gap. So blood sugar should be checked every hourly, but once the patient is stabilized, then it should be checked only 4 hours, because that is also very costly investigation. So initially we have to do hourly and see what is happening to the blood sugar, because rapid fall of blood sugar, rapidly if you are reducing the blood sugar, patient can develop brain edema. So we have to be very careful, especially in children. Potassium should be checked before and during the insulin infusion. That is very important, because shift hypokalemia can occur in patients who is having DKA when we are giving insulin. Other investigation like urea can be elevated in severe dehydration, pre-renal failure, or in patients who is having diabetic nephropathy. Creatinine also can be elevated. Sodium levels are actually very low in hyperglycemia, but patient who is having HHS, it can be slightly normal or high. So you can calculate the serum osmolality from urine, from the serum sodium. That is also possible. WBC normally it is elevated in sepsis or infection. ECG should be taken to rule out myocardial infarction, hypokalemia or hyperkalemia. Now infection screen should be checked, like you can ask for procalcitonin, C-reactive protein, chest X-ray. All these things can be done. Urine routine, urine culture, blood culture. Amylase can be elevated in many patients, but lipase also should be there to rule out pancreatitis. Patient can even have abdominal pain, so we have to rule out pancreatitis. Both amylase and lipase has to be elevated. Now, when we have a patient who is having DKA or HHS, the most important treatment is fluid. Don't think that the most important treatment is insulin. Insulin is important, but it is not most important. Most important is fluid. So, normal saline, 1 liter in first 30 minutes, 1 liter over next 1 hour, 1 liter over next 2 hours, 1 liter over next 2 to 4 hours. This is the protocol. You have to give only normal saline. Don't try other solutions. Other solutions like ringer lactate and all can be used, but ideal solution in correction of acidosis here in this condition is normal saline. If the patient is having hypernatremia, like patient is having HHS, slightly higher sodium, then it is better to go for 0.45 saline or half normal saline. Once the blood sugar drops less than 250, it is always better to switch the fluid to a dextrose containing solution, either DNS or 5% dextrose. That can be started, especially in children. That can produce sometimes brain edema. So normally DKA requires around 6 liters of fluid, whereas HHS requires around 10 liters of fluid. That difference you should understand. Patient who is having fluid overload, like cardiac failure, liver failure, kidney failure, even then if they have DKA, they have fluid deficiency. So you can do in emergency room, you can check for IVC distension or IVC collapsibility or passive leg raising test. All these things can be checked, and when you are giving fluids in patients who already have cardiac failure, you have to always continuously auscultate the patient to rule out pulmonary edema. So that is very important. Monitoring of patient is very important. Now, potassium deficit is next important thing, because DKA, you can see many patients who is having DKA, high blood sugar, potassium will be low. If the potassium is actually low, less than 3.5 and all, you have to be very careful, because if the potassium is low and if you are starting insulin without correcting that potassium, again shift of potassium can happen from the intravascular compartment. Patient can develop further severe hypokalemia. So we have to be very careful when you have a patient who is having hypokalemia. So if the serum potassium is less than 3.5, give 1 liter of fluid, give 40 millicurrents of potassium, then give 1 liter of fluid. Avoid infusion rate more than 20 millicurrents per hour. If serum potassium 3 to 5 millicurrents, give only 20 millicurrents of potassium. If the potassium is more than 5, then potassium is not required. If serum potassium should be maintained between 4 to 5 millicurrents. Remember, hypokalemia before insulin infusion should be corrected. Otherwise, patient develops further severe hypokalemia. That is very important. Now, insulin should be started only after the potassium correction. Normally, we can go according to like different protocols are there. Yale University Delta protocol is the most accepted protocol, but that may not be available in all centers. But the simplest, or you may not have expertise to do that type of protocol. The most simple method of calculating infusion rate, initially give 0.1 unit per kg. That means 70 kg patient may require 7 unit as initial infusion or initial bolus. Then check the blood sugar. If the blood sugar is like 700, first hour you divide it by 100, okay, you get 7. So continuously give 7 units for 1 hour. Then check the blood sugar. If it is 600, then only 6 units are enough. Then after 1 hour, if it is 500, then give only 5 units. Instead of that, when you are giving 700 and 7 units you are giving, after 1 hour it is either 700 or it is 800. You double the dose. From 7 you make it 14 units. So that is the simplest form of insulin infusion. And insulin infusion should be continued till the patient is taking oral feeds. So anytime because of hypoglycemia, you cannot stop the insulin infusion. When the patient blood sugar is reducing, you start dextrose containing solution and give a small amount of insulin infusion. Otherwise, if you are suddenly stopping insulin infusion, there can be rebound DKA. Ketoacidosis can rebound. So we have to be very careful. You have to continue it in a very small dose, small possible dose should be continued. So this is Yale University Delta protocol. If you can remember, or you can copy, or you can download from internet, that will be very useful. And if you are able to follow this protocol, that is also very good. That is a perfect protocol, but previous one was the easiest protocol we discussed. Now, normally when we are giving fluid itself, blood sugar will drop in this range, and that is all required. We no need to reduce the sugar very fast. Whether it is with your IV fluid or insulin infusion, sugar drop should be 50 to 75 milligram per deciliter per hour. That's all. We no need to reduce it very fast, because that can produce brain edema, hypoglycemia, all complications. So we don't reduce it very fast. Initially, when you are giving fluid itself, you can see the blood sugars are coming down. And then when you are starting insulin infusion, again it will drop. But rapid drop of blood sugar is not good for the patient or his brain. So that is very important. So if the patient develops hypoglycemia, better to reduce the insulin infusion. If it is very low, only stop the insulin and give dextrose containing solution. Otherwise, you have to continue the infusion. If it is normal, suppose it is very low and you give dextrose and restart the insulin infusion, that will be a better protocol. because suddenly if you are stopping the insulin infusion for a longer period, then patient can develop a rebound decay that you should remember, and you can stop temporarily and give dextrose containing solution and correct it and continue the insulin infusion afterwards. So that is very important. Bicarbonate therapy is a controversial thing in DK. Normally we don't give bicarbonate, but some patients who is having cardiac failure and all, cardiac failure or arrhythmia, we can try bicarbonate in severe acidosis, but as a routine treatment protocol, we don't use bicarbonate in any of these DKA patients, but some physicians use it as a bridging therapy in DKA with acidosis. So bicarbonate therapy can be given in conditions like severe shock coma, severe acidosis less than 7, acidosis induced cardiac and respiratory dysfunction, severe hyperkalemia. There also you can give bolus sodium bicarbonate then infusion. Otherwise we don't recommend it. Supportive measures like you can catheterize, nasogastric tube should be placed, central venous monitoring can be done, plasma expanders can be given, like albumin can be given. Antibiotics are very, very important. So we should never forget antibiotics. Another important thing is magnesium. That is also very important because insulin action requires normal magnesium level. Now, complications, patient can also develop complications like lactic acidosis, brain edema, especially when you are dropping the sugar very rapidly, you can develop ARDS, disseminated intravascular collapse, acute circulatory failure, shock, rebound ketoacidosis. All these things are possible as a complication. Now, remember in DK, you should remember all these things. You can remember A, B, C, D, E, F, G, H, I, J, K, L, M, airway, breathing, circulation for all patient, diabetic history, blood sugar controls, HbA1c, all these things, electrolytes, especially potassium and pH, fluid management like IV normal saline or half normal saline in higher sodium levels, glucose monitoring initially hourly, then fourth hourly you can do, hypokalemia to be managed, that is very important. Hypoglycemia to be looked for. Some patients can develop hypoglycemia. Insulin infusion 0.1 units per kg starting dose, then insulin infusion can be continued. JVP or CVP should be monitored in patient who is having already having fluid overloaded conditions. Ketone bodies to be observed, and when it is negative only you can stop the insulin infusion. Lower dose of infusion should be continued till you fix the dose of regular insulin. So you'll be continuing your insulin infusion like this when the ketone bodies are negative. Here you give the regular insulin, continue insulin infusion for some more time, then only discontinue infusion, then continue regular subcutaneous infusion. Monitor blood pressure, sugar, oxygen saturation, mental status, fluid intake, output chart every 1 to 4 hours. These are important. So remember the total management like this way. And we have discussed about one of the important problem in diabetes, that is diabetic ketoacidosis. So ketoacidosis and HHS, there is basic difference. HHS large amount of volume is lost. Insulin deficiency is not that much comparing with DK. DK fluid loss is less comparing with HHS. Ketone bodies are produced in DK, that is not there in HHS. Treatment wise, there is no much difference. HHS require little more fluid, maybe 3 liters extra more than DK. But insulin infusion requirement is very high in DK, but comparing to DK, it is less in HHS. Thank you.